Thank you for joining us today to discuss coverage and billing of the Medicare Annual Wellness Visit. My name is Karen Curtis and I will be your presenter. Joining me today is Bailey Lawson. She is going to be helping me out by watching for questions that may come through the chat and providing some additional information during the webinar. You've seen her already add some links and some dial-in information, things like that. The annual wellness visit is a topic that has been discussed in multiple areas. Providers have let us know from completed surveys that this is a subject where they would like to see more education. Annual wellness visits have been discussed in MAC collaboration meetings as a topic needing further education, and the Recovery Audit Contractor, or RAC, has found issues with billing excessive units, billing sooner than the patient is eligible to receive the service, and incorrect coding. So we want to make sure that we kind of cover all that information today and get those billings sent correctly. My goal today is to help define the difference between the different physical exams covered by Medicare, components of the annual wellness visit, how to bill for those services, including checking eligibility, and resources that can provide you with guidance. Now, at the bottom of the slide, you're going to see a little reminder to review the legal disclaimers at the end of the slide deck. These just let you know that CMS does prohibit the recording of our webinars. And because I use CPT codes and information that's related to the UB04, the American Medical Association and the American Hospital Association are not responsible for any of the information that I present today. Now, Medicare is full of acronyms, so I did want to put some of these out here. A lot of you may be familiar with all of them, if some of these or all of these, but I like to include them just because there could be people who are either new to Medicare, or maybe they just work in a field where they haven't had to know what all of these abbreviations mean, or acronyms mean. So I did want to put them out here. If I mention anything that you haven't heard of, you can refer back to these. So I want to start out with some definitions. There are different types of exams that can be provided, and each one of them has different coverage. So in the world of Medicare, when we talk about physicals, there are 3 exams that most likely come to mind. The initial preventive physical exam is for beneficiaries who are new to Medicare, and it is often known as the Welcome to Medicare Preventive Visit. This exam is done within the first 12 months of entitlement to promote good health and disease prevention by reviewing the patient's medical and social history. Since the patient is new to Medicare, this would also be a good time to discuss the different preventive services that Medicare covers. The annual wellness visit is an exam that occurs after the initial 12 months of Medicare entitlement. Now, the goal is to provide recommendations which help patients live a healthy life. This can include developing or updating a personalized prevention plan and performing a health risk assessment. Well, a routine physical exam is a visit that is not related to a specific illness, symptom, complaint, or injury. This form of physical exam is not covered by Medicare. There are a couple of requirements for the annual wellness visit. Exams should be performed by a health professional. I've listed some examples here. I do want to provide a little bit of clarification on the third bullet because of a question that I received in the past. A licensed practitioner is a person who is licensed by the state and is qualified to provide care, treatment, and services. Direct supervision means that the physician or non-physician practitioner who is billing Medicare for the service must be present in the office suite and immediately available to provide assistance and direction during the time that the service is being provided, but they do not have to be directly in the room. Medicare also requires that at least 12 months have passed since the patient became entitled to Medicare Part B. They also must not have had an initial preventive physical exam or an annual wellness visit in the 11 months preceding the current exam. I'm sorry, 12 months. We'll go over the 11 months in just a little bit. So not every annual wellness exam will be the same, but it should always include a discussion regarding a patient's individual and family medical history. You'll also want to include routine measurements such as height, weight, BMI or waist circumference, and blood pressure. For the initial visit, discussions may be in more detail because you're trying to establish a general idea of the beneficiary's health. Is the patient at risk for certain illnesses or disease? Are they eligible for other preventive services? Are there risk factors that need to be addressed? On this slide, I have listed CMS requirements for topics that should be discovered and or discussed in the first annual wellness visit. The first one is to perform a health risk assessment or HRA. I'm going to cover this topic in a little more detail in just a few minutes. Next, establish medical and family history. Find out if the patient has any allergies or illnesses. Are there past surgeries or hospital stays? This is also a good time to discuss the health of the patient's parents, siblings, and children. Identify conditions that could be hereditary. This is going to allow you to develop a plan on how to provide the best care for each individual. You'll also want to determine if the patient is currently taking any medications or supplements. Obtain a list of providers and suppliers who are regularly involved in the patient's medical care. Collect measurements of height, weight, BMI, and blood pressure. Check for cognitive impairment. Some factors may be harder to evaluate. Now, while tests can determine if a patient is experiencing a loss of vision, they may not know that they're having memory issues or changes in behaviors. Providers may be able to obtain this additional information if the patient is accompanied by a family member, a friend, or a caregiver. This cognitive assessment can be used to detect signs of dementia, depression, or anxiety. Review depression risk factors. Discuss any current or past experiences with depression or other mood disorders. Review the patient's functional ability and safety level through direct observation or screening questions. Is the patient having problems with daily living? Are they experiencing vague pain or fatigue? This could lead to discussion as to whether the patient needs assistance from family or caregivers. Can the patient continue in their current living situation, or do they need to look for assisted living facilities? Next, establish a written screening schedule for the patient to follow. The Medicare Preventive Services tool listed in the resource slide has a link for a checklist that will allow beneficiaries to track their preventive services. We will take a look at that a little bit later. Establish risk factors and conditions that could lead to the development of chronic disease. Examples would include physical activity, nutrition, and tobacco or alcohol use. Provide personalized health advice and referrals if appropriate. Maybe the patient could benefit from one of the other Medicare preventive services such as diabetes prevention and training programs. Depending on the identified risk factors, maybe counseling for smoking or alcohol misuse may be appropriate. If the patient is open to the topic, advanced care planning may be discussed. I will also talk about this in a little bit more detail since it is a separately billable service. If the patient has an opioid prescription, screen for any opioid use disorders. Evaluate their current treatment plan to see if any changes can be made. Maybe a switch can be made to a non-opioid treatment for pain management. Screen for any substance use disorders and refer to treatment when appropriate. And lastly, the optional social determinants of health risk assessment can be performed. I will also cover this in a little bit more detail because this is also a separately billable service. Now, during subsequent visits, you will want to review and update those components of the initial annual wellness visit. Routine measurements such as weight and blood pressure should also be taken during this visit. It is a good idea to review any information that was given on the initial visit, as changes may need to be made to the plan of care. Some patients may be seeing multiple doctors, so you'll want to see if there's any changes to their medical history. Did another physician add medication to their daily routine? Have they been referred to any new healthcare providers? Are there any other preventive services that they received since you last saw them? Things like that could all make changes to their plan of care. We also want to update their PPPS, provide voluntary. You can still do the voluntary advanced care planning. Again, you'll want to review those opioid prescriptions, screen for any substance use disorders, and the SDOH risk assessment could be performed again at those subsequent visits. So let's cover the health risk assessment in a little bit more detail. The Center for Disease Control reports that 6 in 10 Americans live with at least one chronic disease. They are the leading driver in healthcare costs, and they often are caused by changeable risk factors. They've also determined that there are many patients who do not receive recommended preventive services and follow-up treatment. So beginning in 2011, Medicare began offering a health risk assessment as part of the annual wellness visit at no additional cost. The HRA is an opportunity to receive self-reported information, and it shouldn't take more than 20 minutes to complete. Some of the information collected in the HRA overlaps with the other areas of the annual wellness visit, but it includes demographic data such as age, sex, and race. Ask the patient how they perceive their health. This can help you determine what type of education they may need regarding their own healthcare needs. Psychosocial risk can also go along with reviewing depression risk factors. Does the patient experience a lot of stress, anger, or pain? Are they lonely? How satisfied are they with life? Some behavioral risks are covered during the reviewing of the opioid prescription and screening for substance use disorders. Topics of conversation can also include physical activity and nutrition. Does the patient visit a dentist on a regular basis? Do they wear a seatbelt when driving or riding in a vehicle? Ask if they can perform activities of daily living. This can include getting dressed, preparing food, and feeding themselves. If they are no longer driving, do they have a reliable source of transportation? Are they able to keep up with housework and laundry? If they're prescribed medication, are they taking them as required? Things like that all go within this health risk assessment. Advanced care planning is a chance for a patient to prepare in case of injury or illness that is going to prevent them from making their own healthcare decisions in the future. This portion of the annual wellness visit is voluntary, and it should be done face-to-face. This discussion may be with the patient, a family member, caregiver, or surrogate. Part of this discussion may include advance directives and helping beneficiaries fill out legal forms to make sure that their wishes are carried out down the road. Some examples include a living will, medical orders for life-sustaining treatment, a durable power of attorney, and psychiatric advance directives. A living will and medical orders for life-sustaining treatment allows the patients to make decisions regarding what medical treatments they would and would not like to be used to keep them alive. Maybe the patient wants to assign someone they trust as a durable healthcare power of attorney who will be able to make those healthcare decisions for them. The Psychiatric Advance Directive allows a person with mental illness to make their wishes known prior to an emergency. The directive does have two parts, an advance instruction and a healthcare power of attorney. Patients may choose to use one or both parts. The advance instruction portion can provide details on treatment preferences as well as medication choices. Other topics such as childcare instructions or contacting an employer may also be included. If the healthcare power of attorney is added, it can be used for both medical and psychiatric emergencies. A social determinants of health risk assessment was new last year. It is an option that is used to assess a patient's history and help in guiding medical decision making. It takes into account where patients were born, live, work, and socialize. Studies have found that these elements can influence health and quality of life. The SDOH is broken down into 5 categories. The first is economic stability. So this is things like, is the beneficiary able to afford housing and healthy food and adequate health care? It has been shown that those living in poverty are more susceptible to disability and early death. So when you consider those who grew up in poverty, the health issues start earlier than those who grew up in more economically stable environments. Education access and quality. Organizations use the term health literacy. So personal health literacy refers to an individual's ability to find, understand, and use information and services to make informed health-related decisions for themselves and others. Although technology may make things easier and more efficient for some, older adults may struggle with understanding and navigating electronic forms. Today's healthcare is filled with patient portals, electronic health records, and although some adults may be very tech savvy with access to home computers and smartphones, there may be others who are using outdated technology or maybe can't afford a home computer or a tablet, things like that. Healthcare access and quality is important regardless of age, but as we get older, the risk of chronic conditions increases. Older adults are more prone to conditions such as dementia, diabetes, and heart disease. This has been shown that many seniors have at least one chronic condition and frequently have two or more. So most of the time, these conditions require special care and monitoring. Getting access to those services can become more difficult as we age. Some beneficiaries may have lost their driver's license or they don't feel comfortable driving anymore. So now they must rely on family members or caregivers or even public transportation to get them to appointments. Those living in rural areas often must travel further to see providers or specialists. Now, telehealth has helped out with some of that. We must also consider those who are transitioning from an employer group health plan to Medicare. Coverage for items that they depend on may change, and some may have to find new healthcare providers. All of these changes can delay a person in seeking care, and that can just further complicate health problems. Neighborhood and built environment refers to where we live. Beneficiaries who have homes that meet their needs and access to public transportation have a better chance of living independently. Um, is there access to green spaces or trails that would encourage them to get outside and be physically active? These factors can have a positive effect on a person's health and well-being. Now, on the other hand, individuals who are living in lower income areas may be exposed to more violence, unsafe air, water. They may be exposed to conditions that can harm their health. So these factors may be more difficult to overcome as it takes the work of policymakers at local, state, and federal levels to make changes. The last category is social and community context. Interactions with family, friends, and others in the community can have a significant impact on our quality of life. Individuals who have strong social connections have a lower risk of health conditions such as heart disease, stroke, dementia, and depression. Having someone to talk to makes us feel better equipped to deal with stress and life's challenges. I've read articles lately where they have linked untreated hearing loss as a risk factor for developing dementia. They say that those affected tend to become more socially isolated because they have difficulty staying involved in conversations. This can also have an effect on the individual's psychological health, and it may lead to increased risk of depression or anxiety. So now that we've discussed the components of the annual wellness visit, let's talk about coverage. The annual wellness visit is covered under Medicare Part B. Services should be provided at least 12 months after the patient's Part B entitlement date. In addition, the patient should not have had an initial preventive physical exam or an annual wellness visit within the last 12 months. The exam should be performed by a healthcare professional. I've listed details about that in that slide earlier. Copays, coinsurance, and deductibles are waived. This is also true for advanced care planning and social determinants of health risks, as long as they are performed on the same day as the annual wellness visit. Annual wellness visits are covered once every 12 months. So this means that 11 full months must have passed, starting with the month after services were received. So for example, if a beneficiary received an annual wellness visit in January of 2025, you would start counting the 11 months beginning in February. So this means that the patient would be eligible for their next visit in January of 2026. You're also going to want to make sure that 11 full months have passed since the patient had their initial preventive physical examination. And since we're talking about coverage, I want to take a moment to look at the top rejections. This is going from August 1st of 2025 through October 31st of 2025. There have been 6,475 frequency rejections, which comes to 2,588,665 that were not covered. For services prior to coverage, there were 5,255 rejections, totaling $1,703,780. And lastly, services received within 12 months of Part B entitlement had 687 rejections and $947,542 non-covered dollars. During the first 12 months of entitlement, if the beneficiary, that's when they're going to receive that initial preventive physical exam or the Welcome to Medicare visit. So that would be a completely different service than the annual wellness visit. So for avoiding these rejections, the WPS portal does provide eligibility information that can help you avoid frequency rejections. Preventive services that are subject to frequency limitations can be found on the Preventive Services tab. So the top portion of this slide is all the tabs that are available when you do an eligibility check in our portal. The tabs that are blue contain information, while the tabs that are gray do not have any data. Now the information I'm showing is from the Preventive Services tab, so that's why it looks like it's white with blue lettering. So it's going to list each service It's going to have a title and it's going to be followed by rows of information. So the example that I'm showing here is the annual wellness visit. So you can see the procedure codes that have been billed, any modifier that has been used, the next eligible date, a deductible amount, deductible remaining, and coinsurance amount. So that's just something that will help you with knowing when the beneficiary would next be eligible to receive the service. Now for avoiding those entitlement rejections, if we go to the summary tab, then that's going to we're going to look at their Part B entitlement date. So I've got that shown with a little red box around it. So you're going to want to make sure if you're billing an annual wellness visit, it can't be within 12 months of that effective date. So that'd be another way for avoiding those entitlement rejections. So next, let's move into how those claims should be submitted to Medicare. When submitting claims to Medicare, you're going to want to use code G0438 for a beneficiary's initial annual wellness visit. Subsequent visits are going to be billed using code G0439. There is no specific diagnosis code that is required when billing for the annual wellness visit, so you're just going to want to use a code or codes that are consistent with the patient's exam. The type of service should be a 1 for providers who bill on a CMS 1500 or 837P. Because G0438 is specific to that initial visit, it is considered a once-in-a-lifetime code. The recovery audit contractor has reported that they have seen providers billing this code more than once. So I'm not sure if this is due to patients seeing different providers or if it's just a misunderstanding of what code to use. The second code listed is the G0439, and that can be billed annually. If you are a provider who bills on a UB04 or an 837I, I have listed the type of bills that can be used when billing for an annual wellness visit. You can see that the services can be performed in a hospital, skilled nursing facility, rural health clinic, federally qualified health center, or a critical access hospital. I want to talk for a minute about specialty coding. You are a med to critical access hospital claims it professional services in addition to the facility payment. Charges for those services should be billed using the appropriate revenue codes listed on this slide. Now for rural health clinics and federally qualified health centers, the professional portion of the service should be billed using a type of bill 71X or 77X. The claims must include code G0438 or G0439, and deductible and coinsurance do not apply. Federally qualified health centers have an additional option of billing code G0468. This code is used when the visit includes an annual wellness visit and a bundle of Medicare covered services that would be furnished per diem to a patient receiving an annual wellness visit. This code should be billed with the appropriate 52X revenue code. Now, there may be times during a wellness visit when a problem or abnormal finding is significant enough that it warrants performing a problem-focused evaluation and management. The E&M must be performed on the same day as the annual wellness visit. It should be a separately identifiable, medically necessary, and related to treatment of an illness or an injury, or to improve the function of a malformed body part. When determining which code is appropriate, services that were provided as part of the annual wellness visit, such as reviewing the patient's medical history or routine measurements, should not be included in the decision-making process. Modifier 25 should be included on the line containing the evaluation and management code. Another code that should have been added to this slide, I apologize for not having it on here, is code G2211. Beginning January 1st of 2025, code G2211 will be payable even if you report the base code with modifier 25, and only when the service or other procedure requiring the reporting of modifier 25 is an allowed Part B service. I am going to have Bailey add a link in the chat where you can find a little bit more information about that. We're also going to take a look at that when we get to the resources. There's some additional information to show you. If advanced care planning was provided during the visit, you can bill using code 99497 and 99498. No specific diagnosis code is required, so you're going to want to use a code that is consistent with the patient's exam. Coinsurance and deductible are waived if it was performed on the same day with the same provider as the annual wellness visit. Charges must be 33. While there is not a limit to the number of times you can report advanced care planning for a particular patient, deductible and coinsurance will apply if it's provided outside of a covered annual wellness visit. This is a service. If this service is provided frequently, you're going to want to document what change in the patient's health status or decision regarding end-of-life care was made. When the social determinants of health risk assessments are completed, you are going to bill using code G0136. Diagnosis codes should be consistent with the patient's exam. Coinsurance and deductible are waived if it's performed on the same day and with the same provider as the annual wellness visit. Charges must be billed on the same claim with modifier 33. Now, if the annual wellness visit is denied for exceeding the once per lifetime limit, then deductible and coinsurance will apply to the social determinants of health risk assessment. This also holds true if the assessment was performed outside of a covered annual wellness visit. So let's move on to eligibility. And we do have a few options when it comes to checking patient eligibility. We have the WPS Secure Net Access Portal, which is often referred to as the portal. We took a look at some screenshots from that earlier. Users must be registered with WPS to view a beneficiary's eligibility information. Remember to check both the summary and the preventive services tab in order to avoid rejections. The HIPAA Eligibility Transaction System, or HETS, provides access to eligibility data in real time. This option involves submitting files via electronic data interchange, so a trading partner agreement is required. Providers, clearinghouses, and third-party vendors can transmit a 270 request, which will be processed, and then a 271 response is received. Response files are accurate at the time of transaction and should not be interpreted as a guarantee of payment. If you are a provider who uses a clearinghouse or a billing service, they can also provide eligibility information. So now I do want to take a closer look at some of these resources. I'm not going to go through all of them, but the first resource is the Medicare Preventive Services tool. I do have that pulled up already. This is helpful for all preventive services. You have this board with all of the services available. This little T with a circle in it, that means that the service is eligible for telehealth. We are just going to click here on the annual wellness visit. So you can see that it lists the billable codes, coverage criteria, frequency. If we scroll down, it has the patient pay section. It has additional information. Down here, under the other notes, there's advanced care planning. So there's a link if you want to find out more information about that. Also one for the social determinants of health risk assessment. While we are out here, I also want to let you know, if we scroll down here, there is a preventive services checklist. And this could kind of help patients know like what they're eligible for. They can also keep track of what they've received. That is just something that could be helpful to them. I also want to go back, and we brought up the G2211. So there is some information down here about billing for that for that code, when it can be billed. There's a link to the Medicare Learning Network Matters article, so you can get more information on that HCPC code. So I did want to point that out while we are out here. The second resource is actually linked here. I did provide you with a direct link. I do have to say CMS kind of gave me a scare last week when I went to check all of my links. The Medicare Learning Network publications page was completely gone. It didn't exist. So I was a little concerned that this resource wouldn't be available, but yesterday when I came in, I checked it and it's back. It just looks completely different. So if any of you used this resource before, it used to display almost like a booklet, and now it's more of a web page. So here at the top, you'll find a link for beneficiaries, where it just puts the information in a little bit more beneficiary friendly form. Under the what has changed, they added coverage information about the social determinants of health and about a HCPC code G2211. So it lets you know what updates were made. This covers both the initial preventive physical examination and the annual wellness visit. It also lets you know that routine physicals are not covered. We're going to go ahead and click on the annual wellness visit. And here's where it lists all the components. So it talks about the very first annual wellness visit, and then it goes into subsequent annual wellness visits. I'm going to click on this first one here. Now, there is something I want to call your attention to when you go through these elements. So we'll just start with perform an HRA. When you see this wording, at a minimum, collect this information. This is what our medical review nurses are going to be looking for when they review your documentation. In some of these bullets, you'll notice the wording included but not limited to. I have been asked how this is defined by WPS. So I reached out to our medical review, and what they said was that if any criteria associated is not accounted for in the documentation, it could result in a claim denial. So for example, when down here when it talks about reviewing the ADLs, they are looking for the provider to address all items or have a statement such as no assistance with ADLs needed, patient able to perform IADLs without assistance, or patient requires assistance from the husband. Now, alternately, most of the time we see the providers acknowledge a patient questionnaire or a self-assessment of ADLs and IADL functions. Sometimes that's completed before the visit. So that's something else that could just be attached to medical documentation, just so you're covering that. We'll scroll. So it just goes down through all of the elements that we talked about earlier. And a lot of these, you'll see that there is additional links where you can get more information on specific components of the annual wellness visit. I kind of scroll down here. I don't want to scroll too fast for anybody. Down here, we also have annual wellness visit coding, diagnosis, and billing. So that covers the codes that can be used. It says that no specific diagnosis code is reported. Here's where it talks about who can perform it. And we talked a little bit about the evaluation and management service that can be billed with it. There is also a link here for telehealth. I'm going to go over another website in just a minute. More information about the advanced care planning and the SDOH. So now I want to take a look at, I'm sorry, let me go back here. That was the Medicare annual wellness visit. I do want to look at the National Correct Coding initiatives, and the reason that I included this is because a lot of times when I do this webinar, I get, can we build this with the annual wellness visit, or can we build this service with the annual wellness visit? So there are some codes that are subject to procedure edits with the correct coding initiative. So this, I linked to this booklet just because it tells you how to use the tables if someone is not familiar with that. But I do want to scroll down here a little bit. There is a link here to where you can find them. I want to take a look specifically at the procedure edits. And it does have separate tables for both the hospital and the practitioner. I downloaded this earlier because I didn't want to take too much time while you guys were here. But if we open up one of these tables, it does give you a column 1, column 2, effective deletion dates, and if the services are allowed to be billed together, if a modifier is allowed. So a lot of times, one of the big ones that I get is, can we build depression screening along with the annual wellness visit? So in column 1, you are going to want to search for that payable service. So I started out in column 1 with the initial annual wellness visit. And we can see here that I have the depression screening. For this service, it gives you a 0 saying that those two services cannot be billed together. It's not allowed even with a modifier. I will tell you, if you go down here and if scrolling bothers you, please just look away for one moment. But if we look at the subsequent annual wellness visit, which is the G0439, the depression screening is not listed. So you cannot bill a separate depression screening with that initial annual wellness visit, but it does not show that you can't bill it with subsequent visits. So that's another thing that you're just going to want to take into consideration. Make sure you're looking up the correct code to see if you can bill it with the services that you're looking for. So that was all that I wanted to go through with the resources. I do have some questions and answers that I want to go through for the pre-submitted before I look to Bailey to see if we have any questions in the chat. So first, I got asked about telehealth changes that were effective 10/1 and its impact on the annual wellness visit. I am going to have Bailey add a couple links to the chat. One, a couple weeks ago, CMS did update their telehealth FAQ. So let me click on that real quick. So there are, I don't know, there's a lot of specific questions in here. So this would be something that you could just go through and see what they've updated recently. I couldn't find anything specific to annual wellness visits, but there were, I know there's a lot of questions about audio, if it has to be two-way, that there was something about that in there, if that's, you know, what you're looking for. The other website I want to show you is telehealth.hhs.gov. And if we go here and if we go to providers, for best practices guide, we go to view more. And I'm going to scroll down here. Telehealth for older adults. Sorry, this is not taking me exactly where I wanted to go. Here we go. So I clicked on billing for telehealth and it has Medicare. It has CPT codes, a description, time, was the change permanent. So this would be another resource, and here you can see the initial annual wellness visit and the subsequent annual wellness visit. It does say that those are permanent coverage. So that's just another, you may find more information out there, but I don't know exactly what you were looking for as far as telehealth changes, so I just wanted to provide a couple of resources. Next, I got what code to bill when a provider doesn't capture every element of the annual wellness visit. Medical review has said that any of the coverage criteria that is not accounted for in the documentation could result in a denial. So my best advice would be to provide detailed documentation as to what occurred. Did the patient decline to complete an element? You know, make sure to document that. The practitioner may also document his or her thoughts and observations about the patient, but we understand you can't force patients to perform tasks or to provide you with answers. Maybe, I mean, I guess the only thing I can suggest is that just document, you know, trying to get through each of those components and how far you got with them. Next question was, is an updated HRA required for both the initial annual wellness visit and subsequent annual wellness visits? Now, if you look at the guidance provided by CMS, it states to perform an HRA on the first and to review that HRA and subsequent visits. So I would say yes, it's required because CMS listed it as a component of both. The next question I had was clarity on what is needed for documentation. So although we did talk about some of it today, Bailey and I's coworker, Jennifer Boniface, did hold a webinar last week, which was entitled Exploring Annual Wellness Visit Documentation. Jennifer is a registered nurse, and she provides webinars that are a little bit more clinical in nature. So there is a recording of her webinar that is available on our YouTube channel, and it should be on our Encore presentation webpage later this week. So that may be something, if you really want something just dedicated to documentation, I'm going to refer you to that because she took the whole hour and covered that. My next question is, where in the wellness guide does it advise ordering physicians that outpatient laboratory blood testing is not covered with routine medical exam diagnosis? In the old Medicare Wellness Visits tool, the one that I was talking about that looked like a booklet, there was a sentence that mentioned that laboratory tests were not covered as part of the annual wellness visit. Now, with the new site, I didn't see that information. I also couldn't find anything about outpatient laboratory blood testing in the manuals. The information I did find was more that an annual wellness visit is about overall like health and doing a preventive care plan, things like that, where laboratory work is more diagnostic. So I can't find anything specific saying yes or no, it's not covered. That particular information has been removed from the most current reference or resource. So maybe there could be something in that procedure to procedure tables that we looked at. You could check that out. But It has been removed. That was all that I had for pre-submitted questions. We do have a little bit of time. Bailey, has anything come through in the chat?
Yeah, Karen, we have quite a few questions in the chat. The first one is there any way to tell where a patient had their previous wellness on the WPS website? Does it link an NPI?
It does not link an MPI. All it tells you is the date that they would be eligible for the next one. I'm sure it's because, you know, some providers don't want their NPI displayed. So I'm sure that there is some sort of privacy thing that doesn't allow the portal to give that information. So unfortunately, it doesn't give NPI.
Okay, and the next one is, can a comprehensive preventative exam be completed and billed at the same encounter as an annual wellness visit?
I guess I don't know what the components of a comprehensive physical exam would be. I don't know if you're talking about an evaluation and management code. We did cover that, but I guess I don't know if there'd be overlap, so it's hard for me to answer that question.
Okay, I don't see anything. I was looking to see if maybe they had sent in something further to explain that question, but I haven't seen anything, so we'll go to another question. We go back up here. Doesn't the 2026 physician final rule redefine direct supervision so it can be performed virtually via synchronous audio and video in 2026? Will this apply to annual wellness visits in 2026?
That would be the information that I'm assuming that you're talking about, like the telehealth information, and that was available. Those were the last couple of resources that we went over. There was some more information on that. The FAQs did give specifics about the audio.
Okay, and then we have which additional services, social determinants of health, ACP, et cetera, require a 33 modifier during an annual wellness visit?
That would be both the advanced care planning and the SDOH. Both of those require the 33.
If the patient already has an AD or refuses one, can the provider still charge for the service?
Did they say AD?
AD.
I guess I'm not exactly sure what that stands for. Oh, advanced directive. Okay. They already have one, but the provider wants to charge. Can you read that to me again, Bailey?
If the patient already has an advanced directive or refuses one, can the provider still charge for the service?
I would say that they can't charge for a service they didn't perform. And to me, that it sounds like they're not performing the service because the patient already has one. And that's a separately billable code. So I would, that to me, that doesn't meet the requirement to bill one.
Okay, you have 3 minutes left. Do you want to take any more questions or do you want to move on to closing and answer these?
We'll go ahead and we'll move on to closing. I'll answer the rest of these via email. So since we didn't get through all the questions, I will take what we have left, and I'm going to send an email out to everybody in attendance, and we'll go through what I didn't get through today. Thank you, Bailey. So when you disconnect from the webinar, you will be directed to a CMS survey. I'm also going to have Bailey add a link in the chat. Now, I really hope that you will take a moment to provide feedback on how I did today. If you're watching this video as an encore, a link can be found in the description of the video. But the redirect is going to look like what you see here on the right, and we don't have control over how this appears. So we just want you to know that this isn't spam or anything malicious. In our encore videos, the link is going to appear like this bottom picture that you see here, and it will have like a little online survey title. Now, the feedback we received does lead to changes. Chapters have been added to our encore presentations in YouTube, so this kind of allows you to see what are the different points of the video, and you can jump to points that interest you most. Training indicators were added to the descriptions of our webinars to help you decide if the material applies to you. We've also had 2 Medicare education expos based on suggestions for future education topics. We are planning a 3rd one in January, so watch for details on our live events page. Oops, sorry about that. After disconnecting today, you will receive a thank you for attending email that's going to contain those contact hours that can be submitted for continuing education units. If you joined only by phone, you're going to need to contact us, send us an email letting us know your name and the phone number that you use to dial in, and that way we can send a certificate to you. Now, if you do think of any additional questions that you have, those can be emailed for up to 7 days following today's event. So if you have anything else, be sure to get those into us. That brings us to the end of today's presentation. So on behalf of myself, Bailey, and the Provider Outreach and Education team, I'd like to thank you for being here today, and I hope that you will join us for future events. You may now disconnect.